Thanks a lot. So thanks for proposing me to give you this talk about intensive training. I think, okay, we've got it. So yeah, actually just to let you know who I am. Basically, I was trained as a physiotherapist, and then I make a complementary degree in neuroscience, and then a PhD thesis in motor control, already focused on what's going on with children with cerebral palsy. And then after that, I made a postdoc, and during that postdoc, I collaborated a lot with Andy Gordon, and we designed a new possibilities of intensive training, notably including lower extremities and possibly directed to children with bilateral CP. So what I'm going to do today, since I was asked to speak about intensive training, is really to provide you an overview of the different possibilities of intensive training and try to answer with you the question, are all intensive therapies efficient? Because I think that's an important question. So you all know that cerebral palsy is extremely frequent and linked to the lesion in the brain at the start, and depending on the lesion, we may have, of course, a unilateral or a bilateral CP. And if we look in the scientific literature, what we can see is that there are few efficient interventions, few real physiotherapy or OT interventions that are recognized by scientists as efficient. There has been a big literature review by Joanna Nowak in 2013. And that's kind of the map of what she has shown, is that in active rehabilitation, so if we try to improve activity because we want to improve autonomy, and that's the good way to do it, well, we can see that what is in green, it's what is considered as efficient. We have proof that this is working. And if you look carefully, you will see CIMT, so constraint-induced movement therapy, goal-directed, bimanual therapy, context-focused, home programs. You can see that with the exception of Botox, all these therapies have this common point of being intensive. So this drives really, I think, for scientists, but also for parents, is really important to have something intensive, and are all intensive intervention efficient? So to answer that question, I very recently made what we call a systematic review with some of my students. What is a systematic review? You pass through the literature and you have some criteria, you have some specific words. So we entered cerebral palsy plus intensive training, or plus intensive treatment, or plus motor skill learning, which is an important component of intensive interventions. And we look in two databases, PubMed and Scopus, and wouch, we had more than 2,000 articles. From that point of view, to know what is a good article, what will you keep in your systematic review, you have to have some criteria, and the criteria were that articles were in English, we are unable to read Taiwanese or, I don't know, that kind of languages. Children, of course, it had to concern children with CP, not other pathologies, and also we were not interested in models of CP that were developed in animal models. That was not the focus. We had to have methodological qualities of the study, so with a score, we have scored all studies. We have decided that we need a control group to see what's going on, not only if we follow children, but comparing to something else. Because if you just see what's going on before and after, it may also be that it's the natural evolution of the child. Because children with CP, like other children, are evolving with time, and so we cannot delineate effect of therapy if we do not have a control group. It has to be intensive. We decided to put a cutoff at 5 hours a week to decide it was intensive, and it had to target an improvement of motor function. So finally, after passing through all articles, we had 27 articles meeting these criteria. And I'm going to summarize for you what's in those articles. So the large majority, 21st articles out of 27 were directed to the upper extremity of children with unilateral cerebral palsy. So there is a lot of literature that way, and most of that literature is focused either on constraint-induced movement therapy and bimanual intensive therapy. Does everybody know what is CIMT? Yeah? Who? In the children too? No? Yes? Maybe? Who doesn't know? Okay, so constraint-induced movement therapy, it's a therapy where the children are restrained with the less affected arm. It's restrained by a sling, sometimes by a cast, and the upper extremity with the more difficulty is intensively stimulated. So the idea is that children are making voluntary movements, so we are changing environment and making things gradually more and more difficult to help them gaining more movements. It's intensive, it's voluntary control, and it is based on motor skill learning, so it's really with shaping. So this gradual increase of difficulty, okay? Where bimanual intensive therapy, it's kind of the same idea, but voluntary control is used, so no direction of the movement and so on. It's also using shaping and repetitive practice, and it's also intensive, but it's all the time bimanual coordination. It was designed by Andy Gordon, actually, because he thought that it was a bit strange, you know, to restrain the best hand and to push people to do things with the more affected hand, and then, well, the aim, finally, it's most of the time to gain some bimanual abilities, because if you have a unilateral difficulty, then everything that is unimanual generally is easy. So your goals are generally to improve some bimanual stuff. That's why he proposed to move to bimanual intensive therapy. So what you can see is that there were 7 studies comparing constraint-induced movement therapy versus conventional physiotherapy or occupational therapy, and 3 studies comparing bimanual versus conventional therapy. What are the results? For CIMT, there are some clear improvements. So in the quality of movements as measured by a test like the Quest, in motor behavior and hand function, in movement quantity as measured with the amount of movement made by the more affected hand with some captors. And in 6 studies, CIMT was clearly producing more results than the comparison. You have to know that in 2 cases, it was a lower intensity for the regular treatment, so it seemed quite obvious that more therapy should bring more results, but in 2 other cases, it was the same amount of time of therapy. And also, if you combine CIMT with electrostimulation, you have a slightly higher change than if you have no electrostimulation combined. Okay, in one case, at the same intensity, it was compared with occupational therapy that was bimanual, and in that case, there were no differences. Bimanual versus conventional therapy showed an improvement in the quantity of movement of the affected upper extremity, in the arm function, in bimanual coordination, in reaching, and in grasping. So, on one side, it was more unimanual use that was promoted and a good quality. and quantity of use, and on the other side, more the bimanual function. So, of course, after that, people said, CAMT or bimanual. What should I do? There are results on both sides. So there were studies comparing both. And there were actually 7 studies comparing these two methods. And really what they showed is that it's nearly similar. So the improved use of the therapeutic hand, it's similar in both. The improved bimanual use is also improved in both. And you have the same retention at follow-up. So really, these two approaches are efficient, and you can have similar changes. The really specific things is that for goal attainment scale, of course, when you want to attain a goal, it's usually bimanual, it's what I said. So it was a bit better in bimanual than in unimanual, and also bimanual coordination was a bit more improved in the bimanual treatment. Okay, then we've got a good unimanual, a good bimanual treatment, and well, you know how scientists are. They're like always trying to think about what would be best and could we do something else. And they thought that maybe they could combine, like first unimanual to promote some changes and then integrate in bimanual. So this was done in 4 studies, and it demonstrated that it's more efficient than conventional therapy, and it's slightly more efficient than unimanual or bimanual alone. So all the ingredients that you have in these therapies are the intensity, the motor skill learning aspect, the functional aspect. There are always some functional objective. So it's not the therapist saying, we should improve this or that. It's you, parents, and you, children, that we are asking, what would you like to do in your life? What is missing? What would you gain during this time? So that's the functional objective, and that's really something important. And whether they are unimanual or bimanual, it's producing changes. But why? That's another question that we have had, and the idea is that it's producing, it's producing some neuroplastic changes in the brain. For constraint-induced movement therapy, it has already been shown in 2011 that there were some changes in functional magnetic resonance imaging. So really, activity in the brain was modified. It has also been shown afterwards in bimanual treatment by Winstein and colleagues. And Kathleen Friel, who is sitting there, demonstrated something very important with TMS. So I'm going to explain what is TMS. TMS, it's something that we are doing with children, and we are applying a very small magnetic field on the motor part of their cortex, right? And the small magnetic field, if the child is resting, watching a movie, usually, it will produce, if we are on the motor map, it will produce a small movement in the arm because of the magnetic field that is really triggering the movement. And that way we can really see, by recording what's going on in the muscle of the hand and of the arm, what is the cortical map of the affected hand of a child. And what Kathleen demonstrated is that we have changes in this map, okay? They are improving, but they are improving only if we have this shaping that I explained you. So that's what you can see here. You've got children before, after intervention, and at 6 months, and the dots, the color dots, are really showing you what is the motor map of the child. And then it's improved after, and subsequently it's maintained, but it is only for children who have had this kind of gradual increase in difficulty. If you just ask children to move a lot but do not provide this more and more difficult sequence, then you do not have this change at a cortical point of view. So that was for CIMT and bimanual intensive therapy. One other study actually, came out from the systematic review, and it was a study of upper extremity for all children with CP, not only unilateral, and it was the concept of a neurodevelopmental therapy combined with a few hours per day of a cast on the more affected hands to try to have better range of motion, movement, of amplitude, quality of movement, and hand function. So in this study, there was no difference with an occupational therapy produced at a lower rate. So it was not very concluent. If we move toward the lower extremity, so much less studies have been dedicated to lower extremity, but also one study with NDT was directed to the lower extremity of children with cerebral palsy, and again for all children. And they were measuring the gross motor abilities of the children. And what they were doing is comparing 2 times a week versus 5 times a week NDT to see if increasing intensity is increasing the improvement of the children. And that was true. More therapy, what we say conventional neurodevelopmental therapy is more efficient than less. However, NDT was also used as comparison to other studies with motor skill learning that I will describe after. And in 3 other studies, it was shown as less efficient than a motor skill learning approach. So we have some pros saying that more therapy, more efficient, is more efficient, but also even at a higher frequency, it's still less efficient than some motor skill learning approaches. Okay, for lower extremity 2, we have had 2 studies that were reporting some results about some compressive costumes. So TheraSuit and ADELISuit. This is ADELISuit and this is TheraSuit. The idea is that children can move in a voluntary way, but movement is kind of directed by the fact that there are some ropes and elastics maintaining the different parts of the compressive costume. In these 2 studies, it was very clear that there was a therapy, and the therapy was performed with or without the costume. In both cases, there were absolutely no difference between with and without the costume. However, parents and children reported some adverse events. So there were no supplementary motor improvements, but there was a decrease of respiratory function. It was said as it was uncomfortable and warm, and it had presented some hygiene problems for some children. So this is not very concluent. Not a lot of studies, but the 2 going really in the same way. For combined upper and lower extremities, so recently we have some new propositions that are really targeting both upper and lower extremities. So these are either the goal-directed therapies that have been developed for bilateral CP only, and the hand and arm bimanual intensive therapy, including lower extremities that have been developed for unilateral and then for bilateral CP. So, about goal-directed, there are 2 studies, and you see each time I'm providing the number of children from 3 to 12 years old. The key concept of these studies was first to compare intensive therapies with goals I mean really goals that are functional and that are adapted to each child, like I would like to ride my tricycle. That's a goal that is really targeted to one child who wants to do that. And it was compared versus same kind of therapy, but with broad therapeutic goals, like we are going to improve the balance of that child. Okay? You really see the difference between functional goals and therapeutic aims. One are from the parents and children, and the other are really from the therapists and the broad idea of what should be improved by the therapist. And it was compared in a specific training that was motor skill learning based, or with implementing goals and aims in regular therapy, conventional therapy. Okay, well, examples of goals. The other is the Habit Hill. So Habit Hill is the therapy that we have designed with Andy Gordon. So we've got 2 studies, and the idea is that we are continuously stimulating bimanual coordination and locomotor or postural abilities. So it was an adaptation of the original habit, and we have had children when they had to sitting on balls or on unstable supports. That was for children with unilateral cerebral palsy, including very different activities, and then it has been extended for children with bilateral cerebral palsy. The idea is that we are targeting bimanual coordination, lower extremity stimulation, but it includes for both shaping and repetitive practice with voluntary control, so we're not touching children like in CIMT, like in bimanual only therapy, and it is intense. What are the results? So for the goal-directed therapy, clearly we've got an improvement of the functional objectives. Okay, if it is intense, motor skill learning based, and you've got functional objective goals, then you've got an improvement, and this improvement is higher in goal-directed with motor skill learning than in conventional therapy with also a set of goals. Using functional goals, your goals, the goals of your children, is much more efficient than therapeutic aims. And finally, it's important to note that usual treatment performed at an intensive frequency plus goal is the same as usual plus goal. You are not reaching the level of a motor skill learning approach plus goal. What about Habit Hill? So in Habit Hill, we have provided improvements of the functional objectives that we set at the start with parents and children, improvements of locomotor and gross motor abilities, of manual abilities, and of social participation. Why? Again, with Kathleen and with Andy Gordon, we have dived into what's going on in the cortex. And once again, we were able to demonstrate plastic changes in fMRI, but also in techniques like DTI measuring what's going on in white matter. So gray matter is changing, activity is changing in gray matter, but also in white matter. And Kathleen clearly showed that motor maps of the children measured with TMS is also changing when you have a lower extremity component. Okay. So it means that the key ingredients to provide some changes are intensity, of course, but not only. Functional objectives, I mean, having for you and your children clear goals that are reachable for the children and that the children could really see as an output of what he is doing. That's really important. And using motor skill learning, a structured approach, it's also an ingredient that allow to have these changes as shown also at the neuroplastic level. What is still unknown is what is the best dosage. Is it better to have 30 hours or 60 or 90, 3 hours a day, 6 hours a day? We did in Belgium 9 hours a day. So what's the best? We do not have already an answer to that, but Andy Gordon already made a retrospective study to compare 60 versus 90 hours of therapy. So it was 6 hours a day over 2 versus 3 weeks. And what we can see with the Jepsen-Taylor test, so it's a test where the children have to manipulate a lot of stuff. And so we are kind of clocking time. So it means that the higher, the less good is the score, right? So before CIMT, you can see that in the more affected hand of children with unilateral CP, we are there. And with 90 hours, we are going here, while in 60 hours, we are going there. And this difference is maintained with time. The same for the habits, 60 hours versus 90 hours. So if we are going lower, it's better. It's less time to do the same things. And finally, with the assisting hand assessment, which is a game in which children are playing and we are quantifying the help that the more affected hand is providing to the less affected, what we can see is that it's retention that is better with 90 hours, while in 60, even if you have similar or maybe sometimes a bit higher improvement, then after 1 to 6 months, you are kind of decreasing. Okay, so for retention, it seems that 90 hours could be at least a better proposal. So, to conclude, I would say using a kind of lights like Johanna Nowak did, I would say that in intensive intervention, green is for CIMT, bimanual intensive, both combined, goal-directed, and habitual. You can be sure that these are really producing a change. I would say red for compressive costumes. We do not have a lot of study, but results are very clear. And I would say for NDT, I'm not sure. Because we have arguments saying that more NDT provides more changes, but still at the same intensity, it's still less changes than motor skill learning-based approaches. What we are missing in the literature, it's intervention for children with bilateral CP. Over 27 studies that I presented you, only 7 were directed to children with bilateral CP. Intervention, including lower extremity and postural components, are also missing, as well as long-term follow-ups and details of many therapy contents so that it can be replicated. Okay, so we are pursuing both at the Teachers College and in my lab at the Institute of Neuroscience of Brussels, the investigation of the best intensive therapy for children with both unilateral and bilateral CP. So if you want to contact us, either at the Teacher College or in Brussels, feel free to do so or to take some information. We have some trials running with bimanual and unimanual approaches for unilateral CP, and for children with bilateral CP, we have the Habits Hill. So far, a lot of children with GMFCS3 have successfully participated, but we have extended to children with GMFCS4, and we hope that we could go soon further. That's it. I would like to thank, of course, my collaborators, Andy, Gordon, and Kevin Friel, as well as my team, and the co-authors of this systematic review. And finally, I would like to thank you, the families, the parents, and the children, I know you are not coming in Brussels, but still, I mean, other parents and other children are coming and decided, even if they have a huge medical past, even if they don't really sometimes like to have one more assessment, to dive into research, to try to improve things, not only for them, but also for all the children who could benefit from the output of research. And really, I thank you for that.